So we're going to go to the other side of the spectrum. As you know, many patients, as you've seen from the data that Dr. Mohammed has already presented, will be taking insulin as well. And the thing about patients who are on insulin, remember, if they have type 2 diabetes, they will be on the oral agents as well. So this is kind of like additional therapy. And therefore, it adds to that one more layer of complexity. So what I'm going to do is, of course, discuss some of the risk factors that are associated with both hypo and hyperglycemia during Ramadan. I will review the literature and look at the guidance that we have on insulin management in patients with type 2 diabetes. I'm not going to talk too much about the patients with type 1 because that's kind of a separate talk. And I will highlight the results of the DAR Ramadan Global Survey. So we've heard a bit about the epidemiology of type 2 diabetes, and we really have 4 landmark studies that really inform us about the patient characteristics and what they're doing in Ramadan across the regions. The first was already highlighted by Dr. Mohammed, the EPDR, which was conducted in 13 countries, and I think it was the first of the large Ramadan studies that gave us a lot of information. This one was, however, done in the era of the human insulins, and therefore the information that we have sort of 20 years later is slightly different. Then there was the CREED study, which was conducted in Asia, Europe, and the MENA region, so Middle East and North Africa. And then we've had the DAR MENA type 2 studies, and then we'd had the DAR global surveys that was much larger and conducted in 20 countries, and we also participated in that here. So what is evident, as Dr. Mohammed has already shown you, is that a lot of people with diabetes are able to fast, and the mean number of fasted days, whether you look at the EPDR, the CREED, the DAR MENA study, or the DAR global survey, was approximately 27 days. And then there was some people who fasted outside of Ramadan, so they fasted the Shawwal month as well. So these are the sort of 2 things, you know, it's like almost walking on a tightrope for the patients that are on insulin, trying to balance between hyper and hypoglycemia. The things that accentuate the risk for hypoglycemia is, of course, patients that have advanced age with frailty, so age in of itself is not a risk factor. The presence of renal disease, and you'll hear more about that in the afternoon session. Any patient who has hypoglycemia and awareness, those who have tightly controlled or very poorly controlled. And then, of course, I've highlighted the fact that, you know, your risk increases a bit more if you're on insulin or insulin secretagogues. Acute illness is, of course, another factor. So when we look at, in general, the medications that actually land patients in hospital, you will see that warfarin, insulins, oral antiplatelet agents, and oral hypoglycemic agents are by far the commonest. But the most common are insulin and oral hypoglycemic agents are common causes for hospitalization. So if we look at the literature, and this was a very nice review that was done by Alaboud, where he looked at the effect of Ramadan fasting on glycemic control in mainly insulin-treated patients. So he was able to collect 16 studies, and all the studies except one of them actually found that there was some improvement or no change in the glycemic parameters. And the incidence of major complications in terms of, you know, hypoglycemia or DKA were quite negligible. Of course, minor hypoglycemia was reported, but it didn't affect fasting. Postprandial hypoglycemia was a concern in some of the studies, and as I mentioned, the incidence of DKA was quite trivial. So the conclusion from that literature review is that Ramadan fasting for patients with type 2 diabetes on insulin is very much possible. But does the insulin type matter? And this study was conducted by Dr. Mohammed Hassanain and colleagues. And what they looked at is the efficacy and safety of insulin degludec with insulin aspart fixed combination versus the older biphasic insulin aspart. So we're looking at the analogues, but we're looking at a more newer insulin versus the older ones, which, as you saw from the, as I'll show you later, other parts of the world where the newer sort of insulins are not available because of the expense, they're still using a lot of the mixed starts. So these were the participating countries, sort of well represented within the Muslim majority countries. You have Algeria, Lebanon, India, Malaysia, and some patients from South Africa as well. And the primary objective was, again, to compare the efficacy of IDEG-ASP, which is a combination of a basal insulin, insulin degludec, with a short-acting one, aspart, versus the bi-asp 30. And what they wanted to also look at is the safety in terms of hypoglycemia during and after Ramadan. So the primary endpoint was to look at the change in the hemoglobin A1C. And then, of course, the secondary endpoint is to study and look at the proportion of patients who actually got to the hemoglobin A1C targets of less than 7, and to look at hypoglycemia, both nocturnal and severe episodes. So this was the study design. Patients with type 2 diabetes, they were able to enroll a total of 263 patients. It was an open label study, and they were randomized in a 1-to-1 fashion. So patients were assigned to receive IDEG-ASP, and they were taking that twice a day, in addition to their oral hypoglycemic agents if they were on it. And then the other group was taking bi-ASP 30, also twice a day, with or without the oral hypoglycemic agents. And then they were, first they had a screening period. There was the treatment initiation, and then they were followed during the 4 weeks of Ramadan, and then they had the 4 weeks post-Ramadan as well. So in the inclusion criteria, just mainly patients with type 2 diabetes over the age of 18, treated with any of the premix insulin or a basal insulin regimen for at least 90 days before the screening period. So it wasn't something that was initiated as a new treatment. They needed to have a hemoglobin A1C between 7 and 10, and of course with the intention to fast during Ramadan. So I'll just give you sort of like the summary of the results, and what it showed is between the two, the IDEG-ASP and the bi-ASP, there was a similar hemoglobin A1C control, so IDEG-ASP was non-inferior. There was, however, 62% lower rate of confirmed hypoglycemia with the IDEG-ASP, and 74% lower rate of nocturnal hypoglycemia. So similar in terms of A1C and even the total daily insulin dose. The only thing that was different is that you've got a slightly lower hypoglycemia rates, both the confirmed hypoglycemia and the nocturnal hypoglycemia rates for IDEG-ASP compared to the bi-ASP. What about the basal insulin? Again, this was a study that was conducted by Dr. Mohammed Hassanein, and it was a real-world study that looked at the effectiveness of insulin glargine 300 in patients with type 2 diabetes who wanted to fast, and it was also an observational study, and the mnemonic for this was the Orion study. So it was a prospective, again, observational multi-center study, and they were looking at the safety and the efficacy of basal insulin glargine in patients who were planning to fast during Ramadan. So what they wanted to do, of course, is determine the percentage of people who were going to get either severe or symptomatic documented hypoglycemia during Ramadan and then post-Ramadan, because what they did was they enrolled them, had them monitored pre-Ramadan for 1 to 3 months, because you need to get them on the stable dose, and then follow them up during Ramadan and then 1 month post-Ramadan as well. So these are sort of the baseline characteristics and the countries in which the study took place. There were a few from Canada, but the majority of the patients were from India, Pakistan, and the MENA area. So average age is 54, and you remember that figure from the DAR Global survey as well. Most patients were at around that age. BMI overweight, 29.7. Duration of disease, as you can expect, they're on insulin, so more patients with greater than 10 years. And the risk associated with fasting, the majority of them were in the moderate to low risk. And of course, there was about 47.5% of patients also treated with sulfonylureas. So what did the results of that study show? In terms of the hemoglobin A1C, surprisingly or fortunately, the post-Ramadan levels were much lower in terms of the HbA1c. So you can see 7.6 versus 8.1. And this was similar to the fasting plasma glucose as well, a lower reading in the patients that were on insulin glargine 300. And also when you looked at the self-monitored plasma glucose, you tended to have lower readings with the patients that were exposed or given the insulin glargine versus the ones that were taking the other insulins. So looking at then the hypoglycemia is that if they had better glycemic control, did it come at the expense of hypoglycemia? And here again, we can see the proportion of hypoglycemia before, during, and then after Ramadan, just slightly higher numerically, but there weren't any patients that experienced severe hypoglycemia in any of the groups. And then looking at again at symptomatic hypoglycemia, a tendency towards more hypoglycemia in Ramadan if you compare the bars there in the dark green versus pre-Ramadan, but both arms did not experience severe hypoglycemia. So the better glycemic control that we saw with the patients that were on insulin glargine 300 did not come at the expense of greater hypoglycemia. Then we had the DAR 2020 global survey, which was really done during the COVID pandemic. And part of this of the data has already been analyzed and published, and some of the data we're still looking at. So again, these were the participating countries. Their flags are listed there, and the UAE was, of course, part of it as well as part of the Gulf. Now, if we look at the distribution of the insulin types by region, you notice that a lot of the basal analogues were more used within the Gulf area. So the red bar there, there was a greater use of the basal insulins. And the regions such as, in Southeast Asia, they used more of the human insulins, and NPH was used much more in Southeast Asia. Now, that is just because of the healthcare systems you have within the Gulf and the Eastern Mediterranean area, where the availability and accessibility of these insulins are more available, and therefore the patients are on it. What about, so the predominant use of basal analogues in the Gulf region, NPH and the human basal insulins more widely used in the Indian subcontinent and Southeast Asia. And these were the baseline characteristics. Again, age, average about 58, duration of diabetes 13 years. There are patients that were on insulin, and the hemoglobin A1C ranged between 8.7 to 9.4%. Now looking at the rates of hypo and hyperglycemia, so we had 15.6 of the patients in that cohort experienced hypoglycemia, and about 16.3% experienced hyperglycemia. So almost the same sort of rates between hypo and hyperglycemia. Looking at the type of insulin and the timing of the hypos, just as you had seen in the curves that Dr. Mohammed had shown earlier, hypos occurred more frequently between 3 p.m. and 7 p.m. So just before Maghrib, irrespective of the type of insulin that was used. And so the key takeaway points from the DAR Global 2020 survey was that patients with type 2 diabetes on insulin therapy can fast safely during Ramadan. Most patients with type 2 diabetes were going into Ramadan with poor glycemic control. So the average there was above 8%, which might have then contributed to this higher rates of hyperglycemia that we saw during Ramadan. Optimization of therapy and insulin dose titration is important to be able to mitigate both the risk of hypo and hyper. And as we've seen that most of the hypoglycemic episodes were occurring between 3 p.m. and 7 p.m., irrespective of the insulin that was used. In general, however, the severity of hypoglycemia was minimal and there wasn't any need for hospitalization, and there wasn't any significant difference in the hypo and hyperglycemia rate between the insulin analogues versus the human insulins. So now looking at hyperglycemia, and this was from the EPIDR study, which is now 3 decades old. And what it had showed was there was an increased risk of about 5-fold in patients with type 2 diabetes, which was even higher than in patients with type 1 diabetes. It was a 3-fold in patients with type 1 diabetes for ketoacidosis. However, we together with colleagues in Dubai Hospital, were able to do a prospective observational study to look at the incidence of DKA during Ramadan, pre-Ramadan and after Ramadan. And in fact, we didn't see any increase in the risk of DKA during Ramadan. Perhaps it's because we're using, better insulins. They might be one of the reasons why we didn't see much. And in fact, there are other authors as well. Dr. Salim Bashai has also looked at data from SKMC, and they also show that in the last decade, there hasn't really been an increase in the incidence of DKAs during Ramadan. So perhaps the types of insulins that we're using are actually helping with that. How do we mitigate the risk? Again, I've talked about this slide earlier. For patients that are on insulin or sulfonylureas, they need to agree to check their blood glucose levels frequently during Ramadan. If they were not doing that outside of Ramadan, which they should be doing as well, they must at least agree to do that before we can actually give them the green light to say, okay, you go ahead and fast. The other thing that, I make my patients promise is you need to break the fast. If your blood sugar, irrespective of whether you have symptoms or not, is less than 70 or it's greater than 300 milligrams per deciliter. And as you've already seen this slide before, when they should be testing, it's a 7-point sort of profile, but at least you should start off, midday, just before iftar, and then the 2 hours after iftar as well is very important. So looking at the studies actually that have informed us for the guidelines or the consensus is most of the studies have on insulin therapy have been observational studies. We haven't had a lot of sort of head-to-head randomized control trials. One thing that we need to also explain to our patients, because they sometimes get worried about taking insulin during Ramadan, is that the administration of insulin by the subcutaneous route does not cause a patient to break their fast. So sometimes you may take the basal insulin just 1 hour before iftar, and that doesn't actually break their fast. So listed on there is the studies that were done on basal insulins by the different authors. They are old studies. As I've said, majority of them are observational ones. I did show you the Orion study, which was with insulin glargine 300, and the advantage of that is what patients were able to maintain or actually get a better glycemic control without the expense of having more hypoglycemia. And then if we looked at the prandial insulin, again, a lot of the studies are open label observational studies. They may also, the analogues versus the human insulin, they may reduce the risk of hypoglycemia. And then the insulin analogues are usually injected before a meal. The faster acting ones can also be injected after the meal. So if you have a patient who's not really sure about how much they're going to eat, it can also be taken just immediately after the meal. What about the premix? I've already showed you the study between IDEG-ASP and the BiASP. And using the higher ratio of the premixed insulin at iftar is usually a good idea to kind of counteract the high calorie intake that we usually expect our patients will take with the iftar meal. So what about the guidance? Okay, so I've gone over this. So the changes that patients are going to take, and I'm going to start with the long and short-acting insulins first. So the patients that are on a basal insulin, either NPH or insulin glargine or insulin degludec, as once daily, what we usually tell them is to reduce the dose of their insulin by about 15 to 30%, and they would take that dose at iftar, not at suhoor. Now, depending also again on what the patient's glycemic status is before they're going into Ramadan. Say somebody's going in with an A1C of 9%, I usually say don't make any changes in that insulin dose. Watch out for the next, first 3 days and see what happens. If there's a tendency towards having lower sugar readings, then they might reduce it by about 15 to 30%. If they're tightly controlled, so they're going in with hemoglobin A1C 7 and below, these are the patients that would actually need to make a reduction because their risk for having hypoglycemia is higher. What if the patient is on a twice daily basal insulin, such as NPH? Then they would take the usual morning dose at iftar, and they would have to take 50% of their dose at suhoor. For the short-acting insulin, the normal dose is taken at iftar. Sometimes they might need even to take a higher dose to, again, counter the effects of the Vimto and the dates, etc., etc. Of course, they would omit the lunchtime dose, but the suhoor dose has to be reduced by about 25 to 50%. There's a short algorithm that we usually give the patients that are on basal insulin, depending on what their blood glucose readings are. So if they've got a blood sugar reading that's less than 70, they can reduce their dose by about 4 units. If it's less than 90, they reduce by 2 units. If it's greater than 126, they increase the dose by 2 units. And if it's greater than 200, they would need to increase by 4 units. And the same goes with the short-acting insulin. They can increase 2 units or 4 units up, 2 or 4 units down. What about the patients that are on premixed? It's usually tricky. I prefer patients to be on the basal bolus insulins, but if that's what they're taking and that's the only thing that is available for them, for those that are on a once daily premixed insulin, they can take the normal dose at the time of iftar. Those that are on twice daily dosing, they would take their usual dose at iftar, and then they would reduce the suhoor dose by about 25 to 50%. What about the ones that are on 3 times daily dosing? It does happen, very few patients, but some of them are taking the Mixtard 3 times a day. So again, they would just need to omit the afternoon dose, adjust mainly for the iftar and the suhoor doses. And again, they can do the titration very similar to with the basal or the short-acting insulin. 4 units up or down, depending on what the glucose readings are. And usually I give this to them as a piece of paper that is printed, laminated. We have it with our diabetes educators, and they can have that with them in order for them to remember what to do. Right, so to summarize then, we know that there are proven metabolic benefits for Ramadan fasting in healthy as well as in patients with diabetes. The pre-Ramadan risk stratification, I cannot say that enough times, is essential because it guides us and enables us to help our patients make informed decisions. The use of insulins ranging from the rapid-acting to the long-acting analogues to ultra-long-acting insulins and premixed insulins can be safe if they are used in the correct way. Of course, that means that the doses and timing of the insulin should be adjusted during the pre-Ramadan assessment visit, and patients should be supported. There should be a helpline. They should have access to your clinic or to the diabetes educators in case they run into problems, during the first week or mid-Ramadan, on how they can titrate their doses in order to optimize their glycemic control and therefore give them a safe fasting experience. I think that's all I have to say. I'd like to thank you all for your attention and wish everybody Ramadan Kareem, and we're happy now to take questions. Thank you.